Hello, everyone. My name is Luisa Vedano. I am the CEO of the European Federation of Crohn's and Ulcerative Colitis Associations, which is a second-level organization made by 50 IBD patient associations worldwide. I'm really pleased to welcome and thank you for joining the webinar, the IFCCA webinar, Let's Talk Endoscopy, sponsored by Johnson & Johnson. Next one. And I'm also very pleased to be joined today by our panelists, who are Simona Radici, who is the chairwoman of nurses in NECCO from Italy, Dr. Alba Wardi, gastroenterologist from King Faisal Specialist Hospital and Research Center, Saudi Arabia, and Alexandra Mitria, who is a member of the Romanian IBD Patient Association ASFIR and leader of the IFCCA Youth Group. As you can see from the agenda there, we have a great section lined up. First, you will hear from Simona Radice and Alexandra Mitria about the IBD experience of endoscopy, including some research findings and lived experience. Then there will be a presentation from Dr. Alba Wardi introducing Let's Talk Endoscopy, where it will provide an overview of the rationale behind the resource, how it was created, and how it can be used. The final session of today's agenda will be a facilitated discussion, including our speakers, where they will reflect on misconceptions surrounding endoscopy, communication challenges, and the application of Let's Talk Endoscopy. There will be a short audience question and answer with our speakers, where you will have the opportunity to submit questions for them to respond to. You will see the instructions posted in the chat when you will submit your questions. And now, some brief housekeeping rules. Please remain on mute and camera off throughout the session. Please use the chat function to submit any questions, which will be addressed in the question and answer session. And finally, this is a non-promotional educational event. Please do not discuss specific treatments or brands. Thank you. So before we give the floor to Alexandra and Simona, I would like to briefly set in the scene regarding the role of endoscopy in IBD management. For those that aren't aware, endoscopy is a medical procedure that uses a slim, flexible tube with a lens and light to examine the inside of the gut. It's a gold standard for assessing IBD, including Crohn's disease and ulcerative colitis, giving doctors a direct view to diagnose, monitor, and guide treatment decisions. Despite its central role, many patients lack a clear understanding of how endoscopy influences their long-term care. Endoscopy is an essential but often overlooked tool in IBD management. So let's hear more from Simona Radice and Alexandra Mitria as to some of the possible reasons why. So the floor is yours, Simona and Alessandra. Thank you.
Thank you very much, Luisa, for the kind introduction. And then we can start, please go on for the next slide. Thank you. We can start saying that to gather insight into the experience and perspective of IBD patients around endoscopy, an IFCCA patient survey was conducted alongside deep dive follow-up interviews. Why? Because we want to capture the views of healthcare professionals. Interviews with gastroenterologists and specialist nurses were undertaken across countries, and we set up to understand terminology and perception around endoscopy, assess the level of knowledge and awareness, and understand psychological impact and identify preferences for how audiences receive information about endoscopy. We'll now take you through the key research finding, and Alexandra, who lives with IBD, will share their personal experience and reflection. Next one, please. One of the clearest findings from the research was that many patients still see endoscopy as a one-off diagnosis test, rather than a tool used throughout the IBD journey. Only 58% of patients felt endoscopy, 58% of patients felt endoscopy was very important in their ongoing care, and even fewer linked it to treatment decision making. This disconnect is important because endoscopy plays a critical role even when symptoms improve, but no symptoms does not always mean no disease. Healthcare professionals told us they often need to reframe endoscopy, explain short-term goals like symptoms relief, but also medium and long-term goals such as healing. So Alexandra, please, thinking back to your first experience, how did endoscopy feel to you at that point in your journey?
Well, thank you so much, Simona. I want all patients to know that in IBD, the endoscopy is the most important procedure for monitoring our disease progression. I want to share with you my first experience, but not before telling you how I ended up doing my first endoscopy. After several complications and going to doctors, one surgeon recommended me the colonoscopy. This was after 1.5 years of presenting clear Crohn's symptoms, but nobody told me there were Crohn's symptoms. So basically, he just recommended me the procedure without any explanation, and because I was grossed out by the colonoscopy prep, I didn't do it, which made everything worse. So please don't make the same mistake as I did, and if a doctor recommends you an endoscopy, please do it. After another 1.5 years, another doctor recommended me a colonoscopy, and this time my condition was worse. And only then I understood that I have to do the procedure.
Thank you, Alexandra, for sharing those thoughtful perspectives. Please, next one. Another strong theme we heard was around language, not just information, but how it is communicated. Patient told us that medical terms, particularly those describing colon anatomy or gut lining, can make results feel abstract and difficult to understand. Without clear, standardized language, some patients naturally gravitate towards more reassuring terms, like healing or improvement, even if those aren't clearly defined. Healthcare professionals agreed this lack of consistency can overcomplicate conversation, especially after procedure where patients may feel overwhelmed. Alexandra, can you share how language was used in your experience and where communication felt difficult or unclear?
Yes. So at my hospital, they give you a sheet of paper with all of the instructions you need to follow for the upcoming endoscopy. They use a patient-friendly language, but what I would really appreciate and what would have encouraged me more were tips and tricks about how to tolerate the prep more. I had to read by myself that I am allowed to put, sugar or lemon juice in it. One word that was very confusing for me was biopsy, because they said they took a biopsy but didn't really explain what took means and what the biopsy consists of. So also I noticed some differences in terminology used by different doctors. I noticed that and I also don't want to generalize, this is my personal experience, that older doctors use more technical words, while younger doctors may have more time to sit down and explain and use more patient-friendly language.
Thank you, Alexandra. I noticed when you talk, you always talk about doctors, so you didn't have an IBD nurse next to you, I think.
Exactly. So back in Romania, IBD nurses are not that common. So of course it would have helped to have an IBD nurse who would have explained me why we are doing the procedure and why is it important to do the procedure throughout my IBD journey, because you know that this is very important in order to prevent complications and to better control the disease throughout my life.
I understand. Next one, please. So we can see that more than half of patients felt unprepared before the first endoscopy, and fewer than half felt communication was very clear. From the research, fear and anxiety were often linked to bowel prep, sedation, and uncertainty about side effects, especially for newly diagnosed patients. But preparedness isn't just about instruction, it's also about emotional support and feeling seen as individual. Every patient brings different fears, expectation, and level of understanding, which is why personalized, empathetic approaches are so important. Open conversation, particularly around preparation and what the day will actually feel like, can significantly reduce anxiety. So, Alexandra, does this reflect how you felt before your first endoscopy? What stand out most when you look back now?
The feeling that I got most of the time was confusion, because nobody told me why was I doing the procedure in the first place. So many doctors and nurses were all over me at that point, right before putting me to sleep to do the procedure, all talking to themselves, but not to me. The only thing they asked me was, why was I there? And I explained to them that I had fistulas and some infections. And they just whispered, oh, maybe it's Crohn's disease, and they put me to sleep. So now that I want to go back to that moment, I couldn't remember. My current doctor told me, you don't remember that I said maybe it's Crohn's disease right before putting you to sleep? And I was like, no, I don't remember, because this is the after effect of the sedation.
Thank you, Alexandra, for being so open with us. It's not, I think it's quite useful, but maybe it's not very easy for you. So really thank you. Next one, please. After the procedure, many patients told us they technically received the explanation, but they still felt unsure about what the result meant, and sedation played a big role here, as Alexandra said, with some patients unable to remember conversation held immediately afterwards. In this case, visual aids, such as images or drawing, were repeatedly mentioned as a helpful way to explain findings and show differences between inflamed and healthy tissue. Patients also expressed a need for take-home materials, something they could revisit once the fog of sedation lifted. So, Alexandra, looking back, what do you wish you had understood before and after your endoscopy that would have made the difference easier, the experience easier or less frightening?
So it would have been good to understand beforehand the importance of the endoscopy. If somebody would have explained to me that my symptoms are serious and that the endoscopy could give us an answer, I would have done it in the first place, the first time it was recommended. And afterwards, after my diagnosis endoscopy, my doctor told me, well, you are, you may have Crohn's disease, but we have to wait for the biopsy to confirm the diagnosis, and after that you come back and put up a treatment plan. But I couldn't remember anything. Luckily, my mother was there to hear what the doctor had to say, and I asked her on our way to our home, what did the doctor said? What was that, that disease that I may have? And she was like, oh, he said Crohn's disease. So luckily, there was someone there to explain to me what the doctor said, because, as I said before, the effect that the sedation had after gave me a short-term memory loss.
Thank you, Alexandra. Next one, please. So we have just a case just to explain what we are talking about. We have Elena. She's recently diagnosed with ulcerative colitis, and she's currently experiences a clinical remission so no active symptoms, but has been scheduled for a routine follow-up endoscopy. During her consultation, Elena expresses significant anxiety. She tells her specialist nurse, "I feel now fine. I don't want to go through endoscopy. I don't understand when I need another invasive procedure. I'm also terrified about the bowel prep and what happens if I'm too groggy from sedation to understand the results." So based on research inside, we can identify some challenges. The knowledge gap, because Elena views endoscopy primarily as a diagnostic tool rather than a key part of long-term disease management. The preparation anxiety, she's one of the 56% of patients who feel unprepared and anxious about bowel prep. And communication barrier. She's worried about medical jargon and uncoded language often used during post-procedure updates. So the healthcare team should explain that no symptoms doesn't mean no disease. They must communicate a phased treatment approach where the endoscopy used to confirm mucosal healing, which is a critical medium to long-term goal, even when symptoms are absent. And addressing Elena's fears should implement the following patient-friendly strategies. That is, use open conversation to explain the rationale behind the prep, provide simple drawings, photographs, or footage of the colon anatomy to help her visualize the results, and ensure a family member or a friend is present during the post-op briefing, as patients often do not feel awake enough to remember the doctor's explanation. So the team should avoid medical jargon regarding gut lining or colon anatomy. Instead, they should use standardized comforting terms Elena prefers, such as healing, improvement, and treatment success. So using a personalized approach accounts for her emotional and psychological needs. So Elena will feel more empowered and more understandable. This shift from confusing medical jargon to a patient-friendly guide will result in Elena feeling more confident participating in her treatment decision. Next one, please. So in the end, overall, the research showed that a clear need to enhance two-way dialogue between healthcare professional and patient when speaking about endoscopy. A patient-friendly guide can facilitate clearer communication across the stages of disease and educate patients on the importance of endoscopy for long-term disease management. Improved communication between patient and healthcare professional can empower patient to be active participants in their care and feel more confident participating in the treatment decision. Thank you.
Thank you.
All right.
All right. Thank you, Simona and Alexandra. Your presentation was really insightful, and I really appreciate the more scientific side and the experience side that can really give us a clear overview of what it means dealing with endoscopy as a patient, but also as a healthcare provider. So I'm now welcome Dr. Albawardi. I'm delighted to hand over to you to introduce us. Let's talk endoscopy. Over to you. Thank you.
Great. Thank you so much. Good evening, everyone, and thank you for joining the webinar. It's my absolute pleasure to present this part of the webinar about the Let's Talk Endoscopy lexicon. So if we can go to the next slide, please. So as you just heard previously, we had some really important and I think very crucial insight that was gathered from patients and healthcare professionals to really understand the experiences and perspectives about endoscopy when it comes to IBD care. And then this research helped us uncover communication gaps that we wanted to address with this endoscopy lexicon. And it really goes over 4 main categories. One is language and terminology. So patients need a mutually accessible terms to support having this two-way conversation with their healthcare provider. The second category is understanding the role of endoscopy. As you've heard earlier, there is this conception that endoscopy is only used for diagnosis, but as many are aware in this call, endoscopy plays an important role in also management and monitoring. So patients require a clear explanation about the role of endoscopy throughout their experiences, reinforcing why it matters for treatment planning. We also discover the psychological impact of this conversation about endoscopy. So an empathetic and inclusive tone of voice is quite essential when providing advice about what to expect before, during, and after endoscopy. And you probably heard that firsthand with the very insightful comments from Alexandra earlier. And then finally, the results interpretation. So a simple explanation around interpreting the results and using visual aids can support the patient's understanding. Can we go to the next slide, please? Therefore, we put together this Let's Talk Endoscopy, which is a shared language for IBD care. The Let's Talk Endoscopy was put together in partnership with IFCCA, clinical experts, the J&J, and we wanted to tackle these communication challenges through this lexicon. The Let's Talk Endoscopy is a patient guide that's really designed using real-world insight to clarify terminology, address any misconceptions related to endoscopy, and provide some practical tips to help people living with inflammatory bowel disease. We wanted to improve the understanding of endoscopy, the endoscopic outcomes or the results, and also understanding how endoscopy plays a role in achieving the long-term outcomes or long-term care. We wanted to create a set of mutually accessible terms to support clear healthcare professional patient conversations around endoscopy and disease management, and also support patients to understand what to expect around endoscopy and how to interpret results. Next slide, please. So the guide is structured as follows. So the guide is supposed to follow the typical patient experience. So each step describes what patients would expect. So there's a table of key terms with definitions. That way we will simplify to the patients and reduce any medical jargon or terminology, and important questions to suggest asking their doctors when they are scheduled for endoscopy. There's a section on understanding the results with visual aids. And at the end of the lexicon, there's a comprehensive glossary of even broader terms that do relate to endoscopy and also the goals of treatment in IBD. So let's take a closer look at some of these different components of the Let's Talk Endoscopy lexicon. So let's start with the first section. The first section of the guide explains in simple terms what endoscopy is, what the different types of endoscopy, so colonoscopy, gastroscopy, or sigmoidoscopy, and why each of these different procedures can be used at different stages, whether it's diagnosis, ongoing disease activity monitoring, or looking for long-term endoscopic remission. On the second section, we define the more general IBD terms that patients are likely to come across throughout their experience of living with IBD. This includes general terms of IBD, such as Crohn's disease and ulcerative colitis, but they also include some key clinical concepts, things such as disease activity, disease remission, and flare-up or active disease. Next slide, please. The third section introduces key language to be aware of and practical advice at different stages of IBD disease. So beginning with diagnosis, you can see here we define key terms related to endoscopy preparation. This will prepare such patients who are getting, for example, their first colonoscopy when they present with symptoms that are suspicious of having underlying inflammatory bowel disease. The terms include bowel preparation, sedation, and they also cover terms used to describe endoscopy findings such as lesion or inflammation. We've included questions for patients to consider asking their healthcare provider regarding the diagnosis, and also the images that they might find helpful in interpreting the results. Next section, please. So as subsections of the third section, ongoing disease management follows diagnosis, and terms defined in this section are in relation to short, intermediate targets. These are clinical targets used in the context of managing symptoms and monitoring IBD. These include terms such as symptomatic response, symptomatic remission, and also biomarker remission. Following this section is the long-term remission section, which is a core focus for us as healthcare professionals. This section underscores the important role of endoscopic remission and this role in which it plays in terms of the bigger picture of long-term clinical targets in management of IBD. And this is also defined alongside endoscopic response and normalized quality of life. So this really provides a nice sort of spectrum of the expected treatment targets or goal for patients to understand their journey even beyond endoscopy. A visual aid has been included to show these different clinical targets associated with IBD and how they can evolve over time. We go to the next slide, please. Finally, this is the last section. In this section, we have a comprehensive glossary at the end of the guide designed to cover any more general terms related to IBD and endoscopy that the patients are not familiar with. And as you can see from these tables, there are different terms and clear definitions of these terms in language that could be understandable for the patients. Thank you for your attention. We can go to the next slide.
Thanks a lot to our speakers. I think that you have been offering us a great overview of Let's Talk Endoscopy. And now we have about 15 minutes in which I would take advantage. And I would like to ask you some questions regarding endoscopy misconceptions, communication challenges, and the applications for Let's Talk Endoscopy. And I would start with Simona Radice. And so my question is, what are some of the key misconceptions that patients have about the role of endoscopy in long-term IBD management?
Thanks, Louisa, for the question, because many people with IBD think of endoscopy only as a test for diagnosis, not as a tool that guides ongoing care. Fortunately, now we have ultrasound, but ultrasound is not endoscopy. And this is quite difficult to explain to our patient because, of course, ultrasound is not invasive. And they always ask, why can't I have an ultrasound instead of endoscopy? That's why it's so important we can use terminology patient can understand, and not only understand, but put inside their mind and their understanding of the disease. So this is harder to understand why they have to repeat procedure like that. Endoscopy helps clinicians see what symptoms scanned, how the disease is behaving beneath the surface, and whether treatment is truly working. So, as I explained to patient, endoscopy can see what happened in reality inside your bowel. They can have a picture and they can take a little piece of your inside just to analyze it and see what kind of cells are inside. So I understand worries about bowel prep, about sedation or pain, and this always is a big challenge for the patient. A common belief is that no symptom means no disease. This is the awful part to explain to patients, especially with Crohn's disease. Maybe they are really well and they don't understand why. So you have to explain about the complication of Crohn's disease, and I usually use some kind of pictures or drawing or some imagine they can understand, to explain what complication is and why complication can be silent until the end. And so that's why we need endoscopy. And understanding this phase approach helps patients see how each step, including endoscopy, contribute to staying well over time. So the journey to the endoscopy is often fraught with anxiety regarding the mechanics of the procedure, but shifting from technical jargon to a more personalized visual approach using simple drawing, as I said, healthcare teams can transform endoscopy from a feared invasive procedure into an empowering, patient-friendly guide for long-term health. But to communicate with your patient means you know your patient. It's not easy to communicate something with someone you don't know. So you have to know your patient, you have to listen to your patient to understand what kind of language will be friendly for that with that specific person. So this means personalized approach. And I think we nurses are so used to personalized communication. And really, you have to listen to people to understand what is the language they can feel as friendly.
Can you hear me? Can you hear me now? Okay. Thanks, Simona. It was very interesting. And I saw our two speakers nodding. Do you want to add something or to comment on what Simona was saying? Because I think that there are different angles and different perspectives. So it would be nice if you want to add something. Alexandra, please.
Yes, I really enjoyed the part where Simona mentioned about the drawings, because this thing was also done by my doctor when we first met. My current doctor, he started drawing, the stomach and the gut and everything, and made me understand better what is going on. Also, talking from my experience with other patients from Romania, they messaged me and they asked me, why am I not feeling well? I'm on treatment for 3 years and I'm not feeling well. And the first thing that I ask them is, when was your last colonoscopy? And they say, what do you mean? I had one when I got my diagnosis 3 or 4 years ago. And I always tell them, well, this is not right. You have to do it in the early stages. You have to do it at least once a year, or maybe once every 2 years. So yeah, this is very, very important.
Thanks, Alexandra. And Dr. Albawardi, do you want to add something, or you are ready for your question?
No, definitely want to add. I think, there's some really great points that Simona and Alexandra mentioned. But what we really notice is that first endoscopy that the patient gets, it's extremely crucial that they get this experience that makes them comfortable. They understand each step of the way. It's easy for us as healthcare professionals who do this every day to forget that this is a relatively invasive procedure that the patient's going through for the first time. And the reason that first experience is important, because it sets the stage on how often the patient would be willing to come back and get more endoscopies. So this is why in this lexicon, we wanted to include things in that first endoscopy. So making sure you understand exactly step by step what's going to happen, the expectations of bowel prep. And I think one important point is that expectations with sedation, because the sedation is quite variable between different practices. So knowing that you're going to get conscious sedation versus, general sedation or propofol-led sedation is important. So I think for us as healthcare professionals, it's also very important to focus on each endoscopy that the patient gets, but to pay quite special attention to that first one, and knowing, that we need to walk the patient step by step through that first experience, because they're eventually going to need more, even with, newer non-invasive methods, fecal calprotectin and intestinal ultrasound, and still endoscopy plays a major role in disease management.
Thanks, Dr. Albawardi. And then I have a question for you. And the question is, how can we increase understanding? And I think it's very much connecting to what you were already saying in your comment. How can we increase understanding and uptake of endoscopy through improved ACP patient communication? That I can see a red thread in the discussion. Please.
Right. So I think Simona and Alexandra set the stage for this question. Visual aid usually is quite helpful to patients. So knowing that, with this procedure, we're going to look at this part of the colon, then we're going to go all around the colon. We're going to get to that area where the colon meets the small intestines. And for suspecting Crohn's, that's going to be an area that we're going to pay special attention to and try to get into the small intestines. So number one, explaining exactly how the procedure is done, reassuring the patients about pain, because that's very important. So patients will go into this procedure not knowing if they're going to be in pain or they're going to have pain afterwards. Also post-procedure expectations. So what am I going to feel like after the procedure? Am I going to have pain? Am I going to have any bleeding? So I think setting the pre and during procedure and post-procedure expectations, having them set out as clear as possible, will hopefully increase uptake of endoscopy.
Is any of the other panelists willing to add something? Please feel free. I really would like to hear from you, please. Simona, please.
Yes, I think the first experience is really important because even though with the sedation, maybe the patient doesn't really remember well, the body remember very well. And the sensation entering the endoscopy room and having around maybe someone you don't know, it remains with you for a very long time. So I think it's important to reassure the patient that when possible, you will see the same people that that they know in the endoscopy room. And if it's not possible, we must reassure the patient that the people in endoscopy room is someone we know, we trust, and they will take care of the patient, because it's not it's quite an uncomfortable experience, even being quite naked. I think it's not that nice for a patient. So if we can be there, it's better. But if it's not, we have to reassure the patient that the doctor and nurses, they will find an endoscopy room. We know them, we trust them, they are good professionals. So it's not like you just go there. It's just I trust them, and so you have to trust them. It's quite difficult to explain in language which is not mine, but I hope this is I did myself clear.
Yes, of course, Simona. The message was very clear. Alexandra, please.
Now I want to complete what Simona said, and I just remembered my last colonoscopy, my follow-up, the routine colonoscopy. And of course, I always go for the sedation because for me personally, I couldn't stand the pain, and I always think, well, I'm just asleep and the doctor can do his or her job very well if I'm asleep. But my last experience, of course, I am afraid of the sedation, but I do it anyway because it's better for both parts. And I started shivering due to my anxiety, and my anesthesiologist came and asked me, "Are you afraid or are you cold?" And I was like, "I'm a little afraid." And he took my hand and said, "Everything will be fine, trust me." And this was the moment that I understood that I am treated as a human being, as a patient, not just as a fusion of body parts. So this was very reassuring for me.
Thank you, Alexandra. And now it's your turn with my question. And we have been talking about the guide and about how we can better inform or communicate to patients. And from your perspective, how can Let's Talk Endoscopy help patients make sense of endoscopy? Because I mean, I think it can be a useful tool, but we also need to, focus on which parts can really make the difference and how you think it can be used for patients and with patients.
Firstly, Let's Talk Endoscopy lexicon contains real words inside from healthcare professionals and patients to understand how the endoscopy is communicating and what patients need to feel informed and confident. Secondly, it clarifies the terminology, which is very helpful for us. It addresses common misconceptions and also provides practical advice to help patients understand the role of endoscopy in the long-term IBD care. And lastly, it makes conversation about endoscopy simpler and less intimidating, supporting patients to feel more confident in participating in their treatment decisions.
As for the other two answers, are you, dear panel, do you have anything to add? Please.
Yeah, I think Alexander mentioned some really great points. The lexicon also, I think, helps patients throughout their journey. So if this is their first endoscopy and they're just diagnosed, they have that terminology to understand what do these lesions mean, what does inflammation means. But then it also sets the stage of what to expect in the future in terms of short, intermediate, and long term. So it's a guide that they can carry through until their next endoscopy.
Thank you. Simona, you want to add something?
Yes, I think the most important thing is that we work together, which is a great idea, working together, because asking patients what they need is the best way to understand what we do and what we can do better. And writing it down is a great idea because it's useful for me, for the patient, for the doctor, and for the family as well. And so putting ourselves together in the same place and talking about what we need to make us and them better is a great idea. I think we've done a great job.
Thanks a lot. Thanks a lot. So, because I don't know, my microphone is jumping up and down. Can you hear me now? Okay. And first of all, I want to thank you all because I think that the answers and even the debate was really rich and thoughtful. And we also now have the opportunity to invite our online audience to submit questions they have for you, dear speakers, and they can find the instructions posted in the chat. So I will collect the questions and then I will filter them. And so you can say, you don't turn the camera off. So at least I don't see just a colored wall. And I will be waiting for the questions from the floor. We are 2 minutes ahead. That is good. So we have more time for the panel discussion. And I'm waiting for the back office to share the questions with me. There is a long one, but let me check. So I have one that is from our honorary secretary, who is from Malta, and he says, I know there may be instances that although the patient is an adult, using pediatric colonoscopy may be required. It is important for patients to know whether adult or pediatric colonoscopy will be used and inform the doctor about this. So I would start from our doctor. Please, do you have anything to comment or react on it?
Yeah, so it's a good question. So the difference between the pediatric and the adult colonoscope is just the diameter of the scope. the length of the scope is the same. In adults, we do not infrequently use the pediatric colonoscope. It's typically helpful when, let's say, we're doing an endoscopy for what we call strictures, or there's just narrowing in parts of the colon or even the last part of the small intestine or the terminal ileum. A pediatric scope, because it has a smaller diameter, is more likely to get through these areas of narrowing. So I think as a patient, it's probably good to know whether you're, let's say the endoscopist who did your procedure said I could not pass with the adult colonoscope and I had to switch to the pediatric, to just note that for the next endoscopy. It should not really make a difference in terms of the patient experience if they're getting the colonoscopy with sedation.
Thanks a lot. Do you want to add something, Alexandra or Simona, about that? I think that unfortunately IBD in children is growing a lot, so I'm pretty sure that it's something that also family would really need to know better, because when you have to decide what to do with your child, as many information you have, as better it is. So do you have anything to comment on this, please?
Yes, I think talking with the family is different than talking with an adult patient, because what the patient see in their child is different of what the child feels, and these two sense mixed, and it's not that easy. And again, I repeat again, it's important to know the people you have in front of you. You have to let them talk to understand what kind of feeling they have, what kind of relation they have between themselves, because it's really, really important. Talking about a child or a 15-year-old patient is different. A 15-year-old patient is still a child, but he can say what he feels and he can decide. Talking with a 8 years old patient is not like talking with a 5 years old patient. You have to understand what kind of people you have in front of you to understand how you can talk with them. So it's important to know the people. You have to give time to people to make them talk, so you can know them. Time is crucial. The time you give them and you give to the relation before the procedure, it will gain you trust and save time in the procedure itself, I think.
Alexandra, you wanna, as you are the close to the younger generation, do you have something to add?
So this is actually news for me, because I never knew that you could use, pediatric colonoscope on an adult. So I just learned something new today. So this is very good news.
And I think this is one of the added value of talking together and exchanging information, and I think also joining forces, so putting the different angles at the same level and exchanging. I have another question that is from Lady Abigail Snow, sorry. If you could give patients one go-to question to ask their healthcare team about endoscopy results, what would it be? I start from Simona.
I think you should ask to the doctor, first of all, why, and then how, and then when, and then what can I expect? You don't have to be afraid to ask a question. That's the point. Sometimes I see in the visit, a patient are afraid asking question to the doctor because they think, oh, maybe the doctor think I'm stupid, or I don't understand, or I don't want to, or things like that. But you have to ask question to the doctor, to the nurses, because you are the patient. You need to know, because we know. So you need to know. And so don't be afraid to make question. Whatever question you want to. There's no stupid question. There is just question unsaid that need to be done. So it's not really a question, but your question.
Alexandra?
So to answer Abigail with one question from my side, it would be, how can we make ourselves better in order to reach long-term remission? So along with your healthcare professionals and your team, you could also make a plan for the future. So you can ask your IBD nurse or your doctor, what do I have to do in order to be in remission and to be as long as I can be in remission? So this is actually our main goal, right? Because we know that these diseases aren't curable, so we have to live with them for the rest of our lives. So our dream and our desire is to be in remission as long as possible.
Dr. Albawati, you want to add something, please?
Yeah, sure. In my practice, typically, in my patients who either have inflammatory bowel disease or suspected, I typically try to give them a clinic visit or an appointment 2 to 3 days after the endoscopy. We usually talk to them afterwards, but sometimes the effective anesthesia might still be around. And they would ask really great questions, but they might not retain some of those answers. So I tell them, you know what, we'll have a virtual visit, or we'll have an in-person visit 2 days afterwards anyway scheduled. But as mentioned earlier, that you should be comfortable asking any question you have about endoscopy. And if I had to pick, the most important one is you want your healthcare provider or your physician or your nurse practitioner or your nurse to translate these results into, what does this mean for me? What do I need to do? What do we need to do as a team? What medication are we going to go on? When am I going to see you again? How do we monitor? All of those questions are quite important. And again, I would encourage, sometimes it's probably best, if there's going to be a big decision being made after the colonoscopy, is to just schedule a clinic visit a day or two later when the effective anesthesia is gone, more comfortable, you're sitting, in a clinic rather in a hospital bed, to have those conversations.
Thanks a lot. We got a couple of comments, and but before that, I have a question for the panel, our panelists. We have been talking, I've been heard talking about and talking a lot about sedation, but I'm just mirroring a lot of concerns that are coming from the community we are representing, because very often anesthesia sedation is not available in some areas, in some regions. And when I'm talking about regions, I'm talking also in Europe. And it's mainly due to the fact that for some types of sedation, you need an anesthesiologist in the room, and it costs a lot. So very often, even if you ask for, or you don't feel, it's not a question just of anxiety, but you feel pain, etc., sometimes you really have to fight for it and not necessarily win your fight. And this is something that could contribute. This is one side. The other side is the preparation. And I think from one side, this is coming from our community, a suggestion is try to find a better preparation liquids that maybe, it may be a stupid assumption, but maybe I think that the one who will invent this will become really someone who is living in another planet. And the other point is sedation, because when it comes to communicate to patients that they should be fine, that they have to don't be anxious, etc., I think that these two elements, the preparation and the sedation, play a great role, and we should take it into consideration. Unfortunately, it really depends on where you live, in which hospital you are treated, etc. Just we still have 5 minutes. Just one sentence from you, because I still have other 3 comments. Alexandra.
First of all, if we could, invent a preparation with chocolate taste, I will do my colonoscopy monthly. Secondly, about the sedation, yeah, for example, in Romania, there is a big issue because, the biggest center in Romania has a dedicated anesthesiologist. But in other centers, the problem is not the cost, but because the hospitals are understaffed. So there are very, very few anesthesiologists available and too many requests and appointments. So this is also a big issue, because sometimes if you want and you are willing to do the sedation, they will make you an appointment for the colonoscopy maybe 3 to 6 months later, because that is the moment that the anesthesiologist is available.
Thanks, Alexandra. Simona or Dr. Albawardi, you want to add something on that?
Just a little comment. I think we as a team must fight together with the patient to help them to have the best they can have about anesthesiology. I think, and about sedation. About preparation is not easy, because we need really something new to be invented. So we have to help patient to find the best preparation available, and we must encourage them to try the preparation, and we must support them in this. So I think we must work together to get them the best they can have.
Thank you, Simona. Dr. Albawardi, you want to add something? 1 minute.
Yes, I agree, definitely. I think bowel preparation is important. It's also important to ask about the different types of bowel preparations available in the practice. Science is evolving. It's probably at a slower pace than we wanted to when it comes to bowel preparation, but now we have low volume preps compared to the 4 liters. Now we can do preps that are just mixed in about 300 cc's or mLs of water. We have also now pills that act as bowel prep. And then there is now research, nothing yet, about doing a solid meal prep. So we will see if that pans out in the future, but we are making progress.
Thanks a lot. I still have a few comments I want to share with you. One is from Eddie Castro, that is suggesting that it's best to write down the questions when you have to talk with your treating doctor or team in advance, so nothing is forgotten. And then I think that more than a comment, I think that is coming from one of our beloved delegates, Xavier, and he's a professor, he's a teacher, and he says, I always say to my students, there is no stupid questions, there is only stupid answers. And it's my business is not to give you a stupid answer. And I think that this can really close in a nice way, in a very human way, our discussion. And I really would like to thank you, dear speakers, Simona Radice, Alexandra Mitria, and Professor Bavardi. And you have been taking us through the IBD patient experience of endoscopy and introducing us to Let's Talk Endoscopy in an excellent way. I think that your insights into the unmet needs surrounding endoscopy communication and the potential application of Let's Talk Endoscopy Guide are very much appreciated. I would encourage everyone joining us today to take a look at Let's Talk Endoscopy Guide in their own time and begin using it as a tool to improve conversations around endoscopy and long-term IBD care. A link will be added in the Let's Talk Endoscopy guide, will be added to the webinar chat. And again, thank you all for joining us today. Thanks to the panelists, thanks to the audience. And then if you have any follow-up questions after the webinar of today, please write us an email, and the mail will be on screen somewhere. And once again, thank you for your time and have a great evening. Thank you. Thanks a lot.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye bye.